Hi, my name is Meagan Frenette. I'm a nurse at Brigham and Women's Hospital and former ICU nurse in the thoracic ICU. Today, I'm going to talk to you about the care that you'll receive in the ICU after your lung transplant. Today, we'll talk about the ICU team and its function, what to expect after transplant by organ system, and leaving the ICU. First, we'll go through the ICU and the team. The ICU doctors consist of a resident, fellows, and attendings. A resident is a medical school graduate and doctor who is in training. They are supervised by a more senior physician. A fellow is a doctor who has completed their residency and is now in training in a more specialized field like critical care. They are supervised by the attending physician. The attending has completed training and is responsible for the overall care of the ICU patients. The team rotates, so you will see different doctors in various roles. Consults. You may have doctors or clinicians from different specialties come to advise in certain areas of care. For example, a renal doctor for your kidneys or speech and swallow team to ensure you can swallow correctly. Nurses are responsible for carrying out the day-to-day care, such as administering medications, assisting with moving around and getting out of bed, maintaining your safety. They carefully monitor your vital signs and communicate any issues to the rest of the team. Although nursing continuity is attempted, it is not always possible. You may not have the same nurse day after day. The physical and occupational therapists help with walking, teach exercises to build strength, and prepare you to go home. They will assess your ability to perform ADLs or activities of daily living, such as bathing, brushing your teeth, getting to the bathroom, and preparing a meal. They will assess for safety at the time of discharge and may recommend home physical therapy or rehab. Your pulmonary teams. They work in collaboration with the ICU team. This involves the pulmonary medicine team. You may already know these doctors. They're the ones who manage your care for your transplant workup. They care for you across the spectrum of transplant before, while you are in the hospital, and after you go home. While in the ICU, they round with the team daily to manage transplant medications and other aspects of your care. The transplant surgeons are doctors that did the transplant surgery. They also contribute to your ICU care and recovery. They advise on things like tracheostomies, chest tubes, feeding tubes, and other surgical-related aspects of care. The bottom line is everyone works together to ensure the best outcome after transplant. Rounds. Each morning, there's multidisciplinary rounds. The team moves from room to room to discuss each patient in detail and formulate a plan for the day. The team includes ICU doctors, the transplant or pulmonary doctors, your nurse, a pharmacist, and social workers. Also, respiratory therapists. In the evening, there is a smaller rounding session that occurs with the ICU doctors and nurse to discuss the plan for the overnight hours. Visitors and support team. The ICU permits 2 visitors for 10 minutes at a time. This time frame may be shortened or extended at the discretion of the nursing staff. Often, as you become more stable and less critical, visitors can usually stay for longer periods. Please choose one support member to be the point person to call the unit each day for updates and disperse that information to the rest of the family and support team. It takes nurses away from patient care when multiple people call the unit for updates. Transplant precautions are in place for the first week after transplant. Visitors must wear gowns, gloves, and masks when entering the room. Care team members. Your job starts now. You are encouraged to visit and provide support and learn along with the patient. There is a lot to learn, and the patient will need you. Family meetings. These are arranged by the social worker and involve doctors from pulmonary and ICU teams to discuss your progress and plans. What to expect when you're accepting new lungs. We'll review by organ systems. Neurologically. Pain. Pain should be controlled enough that you can take deep breaths, cough, get out of bed, and walk around. You will likely experience some level of pain. To control pain, we use nerve blocks and epidurals. These are placed by an anesthesiologist. They use numbing medicine to decrease pain in targeted areas. Lidocaine patches also use numbing medication on the skin to decrease pain in certain areas. Narcotics can have side effects such as decreased respiratory drive, constipation, and drowsiness. For these reasons, narcotics are used sparingly. The prevalence of ICU delirium is 70 to 87%, so it is common and can vary in presentation. Common presentations of delirium are confusion, agitation, paranoia, delusions, and difficulty paying attention. Some patients can present as withdrawn and sleepy. This can be difficult and sometimes traumatic experience for the patient and their family who see their loved ones not acting like themselves. Delirium will eventually resolve on its own, but it can last days or weeks. Your heart and blood pressure are closely monitored in the ICU. You will have wires connected to your chest, which are connected to a cardiac monitor. This is called telemetry. An arterial line is like an IV that goes into an artery in your wrist. It allows for continuous monitoring of your blood pressure and allows us to draw blood. When your A line comes out, your blood pressure will be monitored at least every hour with a standard blood pressure cuff. Medications are also used to control your blood pressure, either by increasing or decreasing it, to control your heart rate and rhythm, and to prevent blood clots. Your lungs. You may need some supplemental oxygen after transplant. This will be decreased or removed as tolerated. You will do several nebulizers per day to help open up your airways, to help cough up sputum, and to prevent infections. Your nurse will perform chest physical therapy. This is done either by your nurse or a setting on your bed that percusses or claps or vibrates your back to help loosen secretions and make it easier to cough. You will have several tubes that drain fluid and blood from your pleural space. These are called chest tubes. This is the space between your lung and your chest wall. A portable X-ray machine will be brought to your room each morning to take an X-ray of your lungs. The breathing tube or endotracheal tube and the process of removal. The breathing tube or endotracheal tube is a tube that is placed into your mouth and goes into your trachea or your windpipe. It is connected to a ventilator to help you breathe. Your breathing and lung function is closely monitored via oxygen saturations and blood gases. When preparing to remove the tube, the respiratory therapist will first decrease or wean the vent settings to allow you to do more breathing on your own. Simultaneously, the sedation medication will also be weaned. Many sedation medications make you so sleepy that you don't breathe effectively, so it must be decreased or turned off. This part may be uncomfortable. For a period of time, you will be awake with the breathing tube in. Extubation, or the removal of the endotracheal tube, happens when your blood gases and O2 saturations are adequate and there is minimal support from the vent. Tracheostomy. A tracheostomy is a temporary hole made into the trachea or windpipe to allow for assistance with breathing. It is performed when people fail extubation or are projected to need long-term help with breathing. It allows for you to be more comfortable while receiving support from the ventilator. You can go on and off the ventilator and participate in things like physical therapy and rehab while still getting support from the vent. Gastrointestinal. Nutrition is important to allow your body to heal. You may not be able to eat right away. First, the team will need to make sure you are able to safely swallow. If you can't safely swallow, you will need to be fed via a tube feed or IV nutrition. In the meantime, a speech and swallow therapist will be able to work with you to do exercise to strengthen your swallowing. Elimination. You will be given daily stool softeners with the goal of having daily bowel movements. Urinary and kidneys. Intake and output measurements, or I's and O's, are carefully measured every hour. This includes everything that goes into and comes out of your body, such as IV fluids and anything you take by mouth or drainage from your chest tubes and urine. Your urine is drained via a tube inserted into your bladder. This tube can be removed when you can safely and consistently use a urinal or a bedpan. Measuring your I's and O's helps us determine if you need more fluid or need fluid removed. We can add fluid through your IV and remove fluid with medications called diuretics. Your kidney function will be carefully monitored. There are cases in which patients require dialysis to support the kidneys. This can be short or long-term. Walking. Walking is imperative to your recovery. You will be assisted with first sitting upright, then getting out of bed and walking as soon as safely possible. Walking helps build your strength and helps your new lungs function and aids in speedy recovery. You will use a specialized walker called a thoracic walker that can hold all your equipment while you walk. This may feel uncomfortable and difficult, but it is one of the most important things you can do to help yourself recover. There will be lots of people around to help. Leaving the ICU. Patients can leave the ICU via the TICU or Thoracic Intermediate Care Unit or rehab. Patients can go to the TICU when they are clinically stable, do not require a ventilator, and are progressing with physical therapy. There is less frequent monitoring and an increased focus on education in the TICU. You will be expected to learn your medication regimen and record them in a new patient diary. You will be expected to walk at least 3 times per day and stay out of bed as much as possible during the day. Patients who go to rehab are medically stable, but still need some ventilator support or more physical therapy before going home. The focus here is building your strength and getting off of the ventilator to safely go home. While in rehab, you are still followed by the Brigham lung transplant team. That concludes the presentation. Please watch more than once, as this was a lot of information to take in. Thank you.